Rapid extrication of a patient from a vehicle requires several EMTs.
No neck looks good.
EMT number 1 should step into the vehicle behind the patient and carefully maneuver the cervical spine into neutral inline position and provide manual stabilization. Then, assess the airway and open it with a jaw thrust if necessary. EMT number 2 should approach the patient from the side and quickly examine the neck, apply the cervical immobilization device, and support the torso.
Okay.
EMT number 3 should place a long backboard near the door. Move to the opposite side of the car to free the patient's legs. At the direction of EMT number 1, rotate the patient in several short, coordinated moves until the patient's back is in the open doorway with their feet on the passenger seat. The patient's back should be quickly examined. To provide support for the patient's head and neck, another EMT must step in to provide support. Place the long end of the backboard on the seat under the patient's buttocks. Have other public safety officials support the other end of the board as the patient is lowered onto the board. Move the neck and back as one unit. Slide the patient into proper position on the board in short, coordinated moves on the command of EMT number 1. Secure the patient to the long backboard. Move the patient to the ambulance for further evaluation and treatment. There are several variations of this technique. Whichever technique you use, never compromise the spine while performing this skill. Prior to inserting an endotracheal tube, be certain the cuff holds air and inflates properly. Select the proper size endotracheal tube. Insert the stylet into the tube. The stylet must not extend beyond the tip of the tube. It is best if the end of the stylet is kept a quarter of an inch away from the cuff or the proximal end of Murphy's eye. Check the cuff to ensure that it holds air. Leave the syringe attached. For easier placement, consider forming the endotracheal tube into a hockey stick shape. Select the appropriate type and size blade. Connect the blade to the handle and check that the light is bright, white, steady, and tight. Adequately ventilate the patient because the patient will not be ventilated during intubation. Align the patient's head. Hold the laryngoscope handle in your left hand. Insert the blade into the right corner of the mouth and sweep the tongue up and to the left. The tip of the curved blade should be placed into the vallecula. The tip of the straight blade should be used to directly lift the epiglottis. Lift the tongue with the laryngoscope and visualize the glottic opening and the vocal cords. Lift the laryngoscope up and away from the patient, taking great care to avoid pressure on the teeth. Insert the endotracheal tube with your right hand. Insert the tube through the glottic opening until the cuff just passes the vocal cords. Note the markings on the tube at the upper teeth or gum line. Remove the laryngoscope blade and extinguish the light. Do not let go of the tube until placement is confirmed and the tube is secured. Remove the stylet. Inflate the cuff with 5 to 10 milliliters of air. A seal has now been created. Ventilate the patient and confirm proper tube placement. Listen with the stethoscope over the epigastrium during the first ventilation. No gurgling sounds should be heard. Listen to the lungs. These sounds should be equal. Listen to the left and right bases of the lungs. These sounds should be equal. Confirm tube placement by at least one method by observing an improvement of heart rate, skin color, and general patient condition. Equal chest rise and fall during ventilation. Color change on carbon dioxide detectors. High pulse oximetry readings, or improvement in the patient's mental status. Note the markings on the tube at the upper teeth or gum line and record them. Finally, secure the tube and place an oral airway or bite block into the patient's mouth to prevent the patient from biting on the tube. Continue to ventilate.